So welcome, everybody. We'll give it a few minutes for people to filter in. Maybe we have one or two meetings that are right before this ending. Okay, good. I think we've got a good number of folks online now, and I think usually people continue to filter in, but why don't we go ahead and get started so we leave plenty of time for our presentation and also for questions. So today we're delighted to have a guest speaker from Washington University in St. Louis, Dr. Zainab Mahmoud, who is an implementation scientist, among many other things, who will be presenting today Cardiovascular Health in Pregnancy, Opportunities for Prevention and Implementation. And we're going to, Mukhtar Aliyu is going to provide a bio and introduction. He is the director of the Vanderbilt Institute for Global Health. But I think before we turn it over, I just also want to mention that this is part of a sort of mini series that we're going to be running at the end of 2025 and the beginning of 2026, highlighting different leaders in the implementation science field, hopefully to begin to build interest and also education around implementation science and HIV. So Mukhtar, thanks for joining us. He is out of the country and it is very late where you are, but he'll provide our introduction for us. Thank you.
Thank you, John. It's my pleasure today to introduce Dr. Zainab Mahmoud, who is an assistant professor of medicine at WashU in St. Louis in the Division of Cardiology there. Dr. Mahmoud is a physician scientist specializing in cardio-obstetrics with a focus on improving maternal cardiovascular health. Dr. Mahmoud graduated from Trinity College in Dublin, Ireland, and completed her residency and fellowship training at UPenn and WashU in St. Louis. She also has a master's degree in health policy from Imperial College London. Research in implementation science is focused on advancing maternal cardiovascular outcomes. And she's currently supported by K23 from NHLBI. She's the recipient of several awards from the American College of Cardiology, from Merck, and from the American Heart Association. In addition to her clinical and research work, she also serves on the American College of Cardiology's Reproductive Health and Cardio-Obstetrics Council. So it's a pleasure today to have Dr. Mahmoud give our seminar talk. I wish to remind listeners to please use the chat box if you have any questions, and please mute your phones as well. Thank you. Zainab, Dr. Mahmoud, over to you.
Well, thank you so much. Let me just work on sharing my screen. Thanks so much for the invitation and for the kind introduction. All right. I think you can see my screen now.
Yep, looks great.
Okay, well, thank you. So my disclosures are I'm currently supported by the K23 through the NHLBI. I wanted to give an overview of the Nigerian maternal health data, look at postpartum projects we're doing, really highlighting two main projects: postpartum management of hypertensive disorders of pregnancy and aspirin prophylaxis for prevention of preeclampsia, and then briefly discuss future directions. So as some of you may know, Nigeria is the 7th most populous country in the world with estimated population of about 230 million people. And I just wanted to really briefly go over the data in terms of the Nigerian health indices. So as you can see, Nigeria, the life expectancy about 63 compared to the world average, which is 71. So we're way below. And in terms of the top causes of death, maternal conditions come in the top 10, with lower respiratory infections leading the bunch. And just a kind of a map of Nigeria to show you all what parts of Nigeria currently we're working on. So now we're working in Kano and predominantly in Abuja. But the goal is to expand into all the geopolitical zones of the country. So some maternal health data overview. Just wanted to highlight for people who may not know that a Nigerian woman has a 1 in 22 lifetime risk of dying during pregnancy, childbirth, or postpartum. And compared to other developed countries where the lifetime risk is 1 in 4,900. So as you can see, this is a significant risk. And just to go over in terms of maternal deaths, Nigeria has one of the highest rates per 100,000 live births, with 993 deaths per 100,000 live births compared to the global average of 197. Here on the right is showing really how we compare to other countries, especially in Africa. South Sudan is ahead of us, 1,200, 1,000 in Chad. However, because of our the population size, the share burden of maternal deaths is the highest in Nigeria among any country in the world. And it's estimated, I think the total estimate is about 82,000 maternal deaths per year. So some data from the WHO about why are women dying? I'm not sure why the slides are advancing too quickly. Why are women dying? So the top causes of death: hemorrhage, eclampsia, preeclampsia, also will be the hypertensive disorders of pregnancy, which we'll talk about in a little bit more. Other causes are sepsis, infection, and obstructed labor. So as you can see, eclampsia and severe preeclampsia account for 20% at least. And there's thought to be really an underestimation of the impact on this. In addition, the rates of preeclampsia are also rising. So I really like this slide, and I do show it a lot in my talks because it really allows us to look at the world. How would we be if we were like other countries? Just allow us to imagine for a second. So this is the world today. It's not really exactly today. This was from 2015, but the rates are pretty similar. We have about 300,000 maternal deaths. And if the maternal deaths in every country was like Nigeria, about 900,000 deaths per 100,000 live births, we would have 1.2 million maternal deaths. So as you will all agree, that's incredibly, that's a lot. But this is kind of the rates that we have in Nigeria currently. And if we say, how about if we dream and the maternal death rate was about as good as it can get in the European Union, 8 per 100,000 live births, we would have only 11,000 live births compared to 300,000 that we do today. So for me, this really highlights the potential opportunities, because if we can do it in other countries, there's really an opportunity at least to approach that level in all countries. So a lot of my work is around hypertensive disorders of pregnancy. What are they? Chronic hypertension. So this is basically high blood pressure that's diagnosed before a woman is 20 weeks gestation. Gestational hypertension is high blood pressure diagnosed after 20 weeks. So this is thought to be acquired during pregnancy. And preeclampsia is elevated blood pressure with end organ damage, meaning either it affects kidneys, heart, brain. And eclampsia is preeclampsia with seizures. So these are kind of the spectrum. There's another one that's called HELP syndrome, which is really the end spectrum of preeclampsia. And it's pretty severe, but thankfully also relatively rare. So what are the complications that we think about in terms of hypertensive disorders of pregnancy from a cardiovascular standpoint? That's a lot. It can affect, usually associated with chronic hypertension. Patients with chronic hypertension can develop hypertensive disorders of pregnancy, including preeclampsia, but also people with preeclampsia have been shown to develop hypertension postpartum. It also increases risk of other things like coronary artery disease by about twofold, stroke almost twofold, and associated with high risk of atrial arrhythmias such as atrial fibrillation, and increases risk of heart failure fourfold. Overall, increases cardiovascular death in twofold. So as you can see, this is a really important cause of maternal morbidity and mortality among women. And another question that comes up is, when do women die during pregnancy? Sometimes you would naturally think this happens either during pregnancy or right at delivery. But on the left panel here, what we see is a lot of the deaths actually happen postpartum, the majority of the deaths. And some of them happen even after 6 weeks of post-delivery. So when mothers are out of the hospital, they are out of obstetric care, they've graduated from that, those are the times that actually we see a lot of maternal deaths. And on the right here, I'm showing a panel about blood pressure variation during pregnancy. So initially, during early pregnancy, during the first trimester, blood pressure tends to decrease all the way until mid-second gestation, second trimester, where it starts to then rise and peaks at the end of third trimester. Right after delivery, blood pressure tends to improve, but then in some people in the first 10 days postpartum, blood pressure starts to rise. And this is when they're home, they're not being monitored, they're not really having any regular follow-up, and their blood pressure tends to creep up. So since with this realization of elevated blood pressures across the country and in many parts of the world, there have been new programs, postpartum blood pressure monitoring programs that have cropped up to try to detect this elevated blood pressure that happens postpartum. And with that, we can treat it and hopefully prevent these adverse outcomes that happen, including stroke, heart failure that happen relating to these elevated blood pressures. And this I like is a kind of as a slide showing what are the innovative management strategies we can target to this elevated blood pressure, including telehealth. I think since COVID, we've learned to do things differently. Personalized blood pressure monitoring, which I talked about in terms of blood pressure monitoring. I like that community healthcare workers are listed in this innovative slide, even though I think this has been around for a long time. And also, how can these then be linked to increase in adverse outcomes, including decreased readmissions and including both short and long-term adverse outcomes. So just a brief overview of what is postpartum care like in Nigeria. So this was a study that looked at postpartum blood pressure checks and blood pressure checks in women in Nigeria who have had a delivery. Only 37 of them had a blood pressure check within 3 to 5 days. This was a study looking at a few thousand women. And of those who remained hypertensive, only a quarter of them were offered specialist medical review. And for us, this really highlighted a significant gap in the postpartum blood pressure monitoring. Like I highlighted before, a lot of times blood pressure rises after delivery, and we're not really monitoring this or able to address this with treatment. So this really became the foundation of the first project we did, my team and I did in Nigeria, looking at what is the feasibility of postpartum blood pressure monitoring for patients with hypertensive disorders of pregnancy in Abuja. The idea really came about, I was a fellow, cardiology fellow here at St. Louis. We had a clinic where we would check blood pressure in patients who have had preeclampsia. We would treat them appropriately. And I really thought this was a relatively simple intervention, blood pressure checking, treating elevated blood pressures. We could do this in Nigeria. So this was a study to demonstrate feasibility. And it was funded by the American College of Cardiology and ABC. So we really used the consolidated framework for implementation research to try to assess what are the facilitators and the barriers using our qualitative study. We conducted interviews and focus group discussions with healthcare workers, patients, administrators. In addition, we also did a survey using the AIM questionnaire, which is acceptability of intervention measure, really asking participants what they thought of the intervention and if it was feasible to implement in Nigeria. So these were our results. We interviewed a total of 32, and these were the breakdown: physicians, nurses, midwives, administrators, patients, and majority more female actually than male in our participants. So as you can see, pretty much there was wide agreement that this was feasible. Majority said it was completely agreed that this was feasible, appropriate for the setting, and also an acceptable form of measuring, at least monitoring for this population. And using the CFAR, like I highlighted before, we identified what the barriers and facilitators were. And I want to just highlight a few things. Sorry, it's not very clear. This was from the manuscripts directly. I think one of the main things I came across was financial burden. That was a significant barrier that was identified. And other things were lack of protocols that existed and limited knowledge among patients. So we really took this feedback that we got from these qualitative interviews to try to address these barriers that we identified, to then design an appropriate intervention, a contextually adapted intervention for this setting. So this was published in BMC Health Services Research for anybody that may be interested in reading the work. And in addition to the qualitative work, we also did a pilot study where we enrolled 180 postpartum women. 90 of them had hypertensive disorders of pregnancy, 90 without. And we looked at that clinical and demographic data, and we enrolled them in a blood pressure monitoring program, and we followed them up to 12 weeks. And one of the key things I wanted to highlight here, because this was really establishing feasibility, we wanted to see if we could recruit the patients. Are we able to actually get the patients into the study? Our goal was to recruit about 15 per month. We ended up recruiting about 18 per month on average. And our retention, we're able to retain 98% of participants throughout the 2-week blood pressure monitoring time. And we were able to retain 97% through a 6-week monitoring period and 95% at 12 weeks. So for us, this was really remarkable. When we try to do the similar studies in the US, we're lucky if we get 40, 60% retention at least at 6 weeks. So people were not only interested in participating, they were also very engaged and stayed with the program. And as you can see at the top, most of the people that we approached consented. A few of them did not. I think part of it was really didn't consent because maybe their partners didn't want them to be part of it, or they felt that they were too sick and weren't really interested in being a part of it. But majority, more than 90% said yes to the study. And lastly, okay, I'll talk about it actually here. This again was just sharing that our outcomes were a rate of recruitment. We had a target pre-specified, and we looked at fidelity, which was, are they going to be able to do the blood pressure monitoring? So we did a threshold of if they were able to send us 10 daily blood pressure checks within a 2-week period, we would that would meet our primary secondary outcome. And if we're able to retain the participants throughout the period. So like I highlighted in the prior slide. And this was kind of baseline demographics of average age was 30. Majority of them were actually educated at postgraduate level, and majority of them were unemployed or homemakers. And really, a lot of them, I think 40% of them or so, had no income. Comorbidities, I present this data to our clinical colleagues because here in the US, we really think about preeclampsia as something that happens in patients who are diabetic or overweight. And we saw that this didn't really pan out as much in Nigeria. So there might be a different risk profile in Nigeria that we really need to understand better. We looked at our blood pressure trends by diagnosis, and this was over a 12-week period, as you can see below. So we really want our patients to be in the green even at the 12-week mark. That means their blood pressure had come back to normal. So as you can see, even at 12 weeks, majority of the patients that we enrolled in this program remain hypertensive. Just to remind us, this was really not an intervention study. So we were monitoring their blood pressure, but we didn't have a link to making sure that they got treated. What we would do in scenarios where we would detect elevated blood pressure was to refer them back to their doctors. So that was one of the also gaps that we identified during this initial feasibility study, that we really need to have a way to link them to care better. So this was again published earlier this year in JACC, and encourage anybody that's interested to read it. So, like I said, we really learned a lot from our initial feasibility study. So we used the implementation research logic model to map this out. So we put in all the intervention characteristics, the plus were the facilitators, the minuses were the barriers, and try to then map this to strategies that we can then use to come up with a better intervention. So in terms of, and we didn't really address every single thing, we try to come up with ones that are feasible to address. So in terms of things like beliefs, educating them about what the program is and what preeclampsia was, incentivizing participation. In terms of healthcare workers, there was lack of protocols and lack of understanding of who needed to be treated. So training healthcare workers, implementing a team-based care, really engaging with traditional and community leaders when we do the implementation part of it. And another thing that came up was one of the things in the US, we do an app-based follow-up. So a lot of people say, well, how can you do that in Nigeria? But actually in Nigeria, a lot of people have access to a mobile phone. Even if they don't have a mobile phone themselves personally, a member of the family or a neighbor would have mobile phones. So how can we then adapt it and use a text-based program instead of an app-based program? So based on this, we really came up with another implementation study, and these are the aims. We wanted to, based on what we came, all the facilitators and barriers, really adapt the strategies to come up with this HDP implementation bundle that we will then implement. And aim 2 was to evaluate, would this bundle be effective in improving postpartum blood pressure among women with HDP? And then also evaluate some implementation outcomes using the AIM framework. So this was the K23 that we submitted based on that. And luckily we got funded on the first round, and now where the study started this year. We've enrolled currently about 443, this is as of last week, participants. So we're doing a stepwise randomized control trial where we would start with a control period and then gradually in a randomized fashion transition participants to the intervention, which is this HDP implementation bundle that I talked about. And this is kind of initial baseline characteristics, mean age of 28. As you can see, their blood pressure was pretty high at baseline, an average of 144/95. And a majority of our patients have preeclampsia or eclampsia that are enrolled here. So I'm going to stop here in case there are any questions. Otherwise, I will go on and talk about the next study that we did. Okay, I'm going to keep going then. Please feel free to type in the chat. This was funded by an internal award through WashU. And just to highlight, more women die in Nigeria around pregnancy than in any other country in the world. And we know, like I highlighted earlier, that a third of these deaths are for hypertensive disorders of pregnancy. And in addition to morbidity and mortality around the time of pregnancy. Preeclampsia is also associated with future cardiovascular disease, including stroke, heart failure, and MIs, which is acute myocardial infarction, heart attacks. And what we also know from multiple randomized controlled trials, 45 here, that aspirin can effectively reduce preeclampsia risk by 43%. So with this information, I went back to the data that we already collected. This was from the feasibility study. And I said, well, because we collected this data, I'm like, how many participants were on aspirin? We found out 1 out of the 90 people that we recruited were on aspirin. And I was like, well, that can't be true. That can't be right. That would be a huge gap in care. So we went also to another data that we have. So this is a hypertension treatment control program that's ongoing that they've recruited about 25,000 patients. But here we looked at the initial 5,900 patients that they recruited. Of those, 112 were pregnant. And when we looked back to see how many were on aspirin during pregnancy, we found that none of them were on. So we had 2 sets of data that we really showed that aspirin use would be potentially very low. So I said we need to design a study really looking specifically at this question to see how well are we using aspirin? Are there gaps in implementation, and could we improve this? So the objective was to assess utilization of aspirin prophylaxis among pregnant women at risk of preeclampsia in Nigeria, explore the barriers, facilitators, and what are the contextual factors that could affect implementation. And then with this data, we can then inform implementation studies to enhance adoption of aspirin in this very high burden region. So we had a very simple methodology, an explanatory sequential mixed method study. First, we collect the quantitative data. We enroll participants while they're pregnant. We risk stratify them, are they moderate or high risk? And if they're moderate and high risk, these participants by guidelines, the WHO guidelines, should be on aspirin. So we did an initial preliminary analysis. And with what we found, we then conducted qualitative interviews to understand from doctors, providers, why do you think we're not using aspirin as well as we should? What are the barriers there? And then we then presented our contextual findings. So these were our results. These results have not been published, but have been accepted for publication. So they should be published hopefully in the next week or so. We enrolled, there were 1,234 eligible. We enrolled 1,200 participants, and we're not able to completely risk stratify everyone. So of the 1,159 that we're able to risk stratify, 300 were high risk, 30 were moderate risk, and 800 were low risk. So of the high risk participants, these are the risk factors that portend high risk and moderate risk. So these were our findings. Out of 1,159, 31% were moderate to high risk. And of these 359, only 84 reported aspirin prescription. So only less than a quarter of them reported aspirin prescription. So this was really a significant barrier for some intervention that is really cheap, widely available, and highly effective. And we looked at what are the things that are linked to high aspirin use. Early antenatal care. So if a participant came in early, less than 16 weeks, they were more likely to have received aspirin. Other factors were actually higher education and higher income, showing some level of disparities there. Again, through our qualitative work, we mapped out the barriers and the facilitators of aspirin use in this setting. And again, similar things to what we found earlier, the lack of standardized national guidelines, limited provider knowledge. We had cardiologists, we had obstetricians who shared with us that they didn't really know that this was guideline. So really there was a gap there that we could potentially fill. So I think while we highlighted a significant problem, I think really for me, it was more of a huge opportunity to improve care with, like I said, a very low hanging fruit. Aspirin is available everywhere. So if we can implement this, we can really have a potential to improve outcomes at a large scale. So this really summarizing again what I had just highlighted. So this is an interesting slide because I had written this a few years ago. Actually, I was kind of mapping out to myself what I plan to do and looking at formative feasibility study, which we did. And now we're currently doing a hybrid stepwise randomized trial. And then additional thing that came after this was really to do this aspirin formative work. And now we're currently in the process of doing the type 2 hybrid implementation study. So we're about to do a pilot study to establish that we can enroll participants and really hone in our protocol before we do a full implementation study. But there are other kind of, I feel like as we do this work, we find other areas to continually expand. So these are other projects that we're currently working on. This is the PRECISE study, and really trying to understand what the protein changes and echocardiographic changes that occur early on, and can we detect that with echo or blood typing, and determine what are the cardiac phenotypes that are higher risk, and we need to identify early on and engage them in care and retain them in care. So this, the PRECISE study, we're just about to start enrollment in the study, and this will be conducted in Abuja. And this was the AIM study, which is the aspirin implementation and maternity health study. This is really to roll out aspirin across all the geopolitical zones in Nigeria, because for me, I think the key thing is to identify what are the widely available interventions that are evidence-based that we can roll out at a wide scale to improve care. But there's so much to be done, I think, in this field. There's a lot of knowledge gaps in implementation work in Nigeria, or really across Africa, and even in the US. There are really few implementation frameworks that have been adapted for maternal health in low resource settings. Limited data on fidelity, sustainability, and scalability of this proven interventions, such as a blood pressure monitoring. I think that's one of the questions I ask myself: how can we sustain, how can we scale? And really minimal stakeholder engagement. We're very cognizant of engaging stakeholders early and throughout, because I think this will be the difference between success and failure in terms of implementation. And I think a key thing that we're trying to establish is this real world effectiveness and implementation studies, so that we can establish hard data for enrollment. We've tried to do several centers, including WashU. We've tried to do this blood pressure monitoring to really establish that if you do monitor women's blood pressure early on, you can get sustained blood pressure control. But because a lot of the studies are smaller, hard to implement, hard to retain postpartum women in care, we haven't really to date, don't have any concrete data regarding effectiveness, even in the US. So hopefully the study we're doing in Nigeria can fill this gap. Other ideas, I like sharing ideas, even though this could be a potential future grant, but I think there's so much work to be done. And if I can inspire people to take this on, I think that would be great. One of the things we found during our initial study on aspirin was, even though aspirin use was so low, multivitamin use, folic acid use was 97, 98% high. So there are certainly strategies that we've used to implement those interventions, and we can leverage these interventions perhaps to increase aspirin use. And because preeclampsia is so prevalent in Nigeria, we need to ask, is the number needed to treat so low that we really should be treating everybody with aspirin, because it's well tolerated? There's a lot of I think hesitation with aspirin, especially in a place like Nigeria, where postpartum hemorrhage is quite high. And people think if we do give aspirin during pregnancy, we can increase risk of postpartum hemorrhage. Actually, the reverse is the case. Even in randomized trials, there was no signal of increased bleeding risk. And actually, some of this postpartum hemorrhage is actually linked to preeclampsia. So the thought is, if you actually improve preeclampsia rates, you can actually improve postpartum hemorrhage risk. So we here at WashU, we have one of the polypill experts. So this was an idea that we floated. Maybe we can combine all these multivitamins that are given in pregnancy into one pill, and that way we can improve adherence and implementation of this intervention. As some of you may know, Nigeria has the highest rates in the world for peripartum cardiomyopathy. Again, a lot of gaps in knowledge. We still don't understand the pathophysiology, limited screening and risk stratification, really poor follow-up, minimal data on real-world adoption of GDMT or guideline-directed medical therapy, especially in these low resource settings. So a lot of work to be done. Because I know this is a lot of people on here are doing work in HIV. I thought maybe highlighting some of the potential work that could be done in the HIV space. HIV has been linked to hypertensive disorders of pregnancy because it can cause inflammation and cause placental dysfunction that's thought to be the pathogenesis for preeclampsia. So the rates of preeclampsia probably are high in participants with in patients with HIV. How can we really integrate the care, cardio-obstetric care, into the HIV programs that currently are running? And how can we start to think about effectiveness implementation studies in these populations? So I think that's pretty much all I have. I wanted to highlight our study team, which is currently across the US. So mentoring team, these are research assistants, and we have a steering committee as well as the DSMB that keep us on track. And these are some of the team members in Nigeria and some of the WashU team members that came over to Nigeria while I was there. So it's a huge team, but I wanted to take a moment to thank everyone, especially our collaborators and study participants. And